Good evening, everyone. Welcome to the third session on these grand rounds in head and neck cancers. Today, we'll be having a panel discussion on intermediate and loco-regionally advanced laryngeal cancers. Our panel today is comprised of five surgeons. We have Professor Ashok Shah, Dr. Devendra Chokar, Dr. Kendrick Tam, Dr. Pradhan, and Dr. Rajan Kannan, who will be joining us shortly. They're just getting free from the theater. And we have Dr. Tapan Saikia, who's a senior medical oncologist at the HNCII, Dr. JP Agarwal, who heads the radiation oncology department at Tata Memorial, and Dr. Aditi, who is a radiologist with us at the HNCII. So we'll be discussing a few cases today, and we'll have inputs from all of the panelists. So we'll start off with the first case. This is a 64-year-old gentleman who had presented to us with complaints of hoarseness since the last 8 to 9 months. It was a known case of diabetes and hypertension. As we can see, this fiber optic laryngoscopy that was done showed a lesion that was involving bilateral vocal cords involving the anterior commissure extending onto the false cords superiorly, with bilateral cords being mobile. The patient also had a CT scan done, which showed that there was an enhancing lesion involving bilateral true cords superiorly extending to bilateral false cords, with suspicious involvement of the paraglottic fat and preepiglottic fat. There was also a component that was present in the subglottis, and there was no obvious cartilage erosion or extralaryngeal extension, with no significant lymphadenopathy. So, Professor Shah, I'd like to start with you. How would you
How would I evaluate the patient?
Yes, sir.
That was the question I'm going to ask one of your PG, but let me answer that. I think the evaluation starts when the patient comes to your office with the clinical evaluation. What are his symptoms? How long are the symptoms? What kind of airway he is having? And most important, which I think is very critical, what kind of job he is in. I think, last time we talked about it. Is he a farmer? Is
Yes.
he a professor? Is he a lawyer? Is he a singer? I think those important issues when the patient walks in your office are very important. The next is, I think, very critical, fiber optic laryngoscopy. Now, some of the laryngologists are very good with the stroboscopy. I'm perfectly okay with that. As a head and neck surgeon, I'm quite familiar and comfortable with laryngoscopy. Now, what do you look for during the laryngoscopy, fiber optic laryngoscopy? Number one, you want to evaluate the extent of the disease. As you expressed very well, this lesion is on both sides of the vocal cords. And we need to see the exact extent of the disease, how much is the supraglottic, means above the vocal cord lesion. The next is the anterior commissure involved or not. And the last, which is very critical, is what is the subglottic extension. And that may be quite difficult to evaluate. You may need to bring the patient to the operating room. After all this fiber optic laryngoscopy and appropriate documentation, which is very critical, then next comes the imaging studies. At least in the United States, we like to do the CT scan. Some people I know in other parts of the world will do ultrasound. I'm not very sure the ultrasound is very good for laryngeal evaluation. Is it good for the lymph nodes? Probably yes. But we like to do the CAT scan and evaluate both the lymph nodes and the primary tumor. Like you described in this case, I think your description was very important. There is some involvement of the paraglottic area and preglottic area. That literally upstages the tumor. And you start thinking what I want to do. And after this comes the one of the things that we feel very strongly about is the detailed evaluation of the extent of the disease in the operating room. So this patient should go to the operating room both for two reasons. Number one, evaluate extent of the disease. Number two, to make the appropriate decisions how we are going to manage this patient along with the radiological findings And the last, which is very important, is to get a diagnosis. You need a biopsy. Generally, if the lesion is large, we would take a small punch biopsy. If the lesion is very small, 5 millimeter, then the excisional biopsy could be performed.
Yes, sir. So, Dr. Chalker, anything else that you would like to add on, or you would
Uh,
follow the
uh,
same?
Dr. Shah has covered everything, excepting one more thing I would like to add is a speech swallowing evaluation.
Yes, sir.
Uh,
Correct.
he did say we look at the functional aspect of the larynx. So we need to look at whether this patient is aspirating or not aspirating. So besides the anatomical structure and extent, functional evaluation of speech and swallowing preoperatively is important. I would add that besides everything what Dr. Shah has said is perfectly fine.
Okay. So these intermediate and advanced cancers should have a functional evaluation of the larynx to see if there is an aspiration. There are various scoring systems that can be used. The one that we commonly use is the penetration aspiration scale, where they're scaled from 1 to 8, depending on whether the patient is aspirating his own saliva or liquids or no aspiration at all. So this patient underwent a direct laryngoscopy and biopsy. The biopsy revealed that was indeed an invasive squamous carcinoma, moderately differentiated. And so, Chalker sir, how would you like to treat this patient? Since if on functional evaluation he was found to have no significant aspiration.
So even if it is T3, what did you say? Grade this patient?
How would you like to treat the patient? So he would probably
Treat.
be a T3N0
So
based on anything.
considering there is pre-epiglottic and paraglottic spread that upstages the patient to T3.
Yes, sir.
Uh, though the cords are mobile, I would like to add. Of course, I would like to first evaluate the general condition of the patient. ECOG performance state is 64. So we don't go by chronological age, but more by the physiological age of the patient. If he's able to withstand combined modality therapy, that would be ideal in this case. We would like to give chemoradiation. But did you say there is aspiration? Grade 5,
No
grade?
aspiration. No
No
aspiration.
aspiration. So considering there is no aspiration, the cartilage is intact. It's a functional larynx, T3 with almost a transglottic disease, which is going into the supraglottis, a little bit of subglottis. We would like to add chemotherapy to radiation. So this patient is a candidate for organ preservation protocol. Is the short answer. Ideally, with chemotherapy plus radiation therapy, the standard chemoradiation.
Doctor, we also have Dr. Agarwal, who's the expert in radiation. Would you agree, sir, with chemoradiation for this patient?
Ah, Hi. So I would seek more details of the subglottic extension. Just merely saying that subglottic extension present doesn't enlighten me.
Okay,
And
sir.
especially, it will depend how much it is, and my fields may change. And also, in case of failure, uh, you need to know that. So that is extremely important for me, and that's the way I would go. Otherwise, I think in principle, chemoradiation is one of the things, though he has significant comorbidities which are controlled or not. I need to understand that.
I think I fully agree about the subglottic concern. Majority of the failures that we see in early glottic cancers are due to under evaluation of the extent of the disease. And many times, that's why I made a comment before. Bringing the patient to the operating room and getting a good evaluation is very important. Anterior commissure, subglottic area, and you will require appropriate telescopes to evaluate the subglottic area.
So
So
Kanav,
if I
Yes, sir.
Kanav
have to add
add to that.
something,
Kanav
uh,
can add to that.
okay, sorry, Dr. Devendra,
Sorry,
please
sorry.
go ahead.
So what is coming out is, as Dr. Ashok Shah said, and Dr. JP Agarwal, what is coming out is it is important to do both, not only fiber optic scopy and a CAT scan or MRI, but you must put the patient under anesthesia and look at the mucosal extent of the disease under microscope. or your DL scopy, and draw a diagram or document it, the extent of the disease. Because sometimes the mucosal extent of the disease is under or over evaluated on scans. And that is why it is very important to draw these diagrams, especially when you're sending the patient for organ preservation protocols.
I think that
Go
was a
ahead.
very important point that you
Sir,
have
can
spoken.
I add something?
Yes, sir.
My understanding is, let's for the time being assume there is no subglottic extension, but there is an anterior extension in the commissure. So that area also needs to be very, very critically evaluated. How much there is a penetration in that area, because at times what we have seen, there is a failure, there is increased number of failures because of that extension going way back in the cartilages area. So that area needs also to be evaluated very, very carefully.
Yes, when there is the anterior commissure involved, we must always be wary about early cartilage invasion, like we've always stressed upon. Psyche, sir, would you be happy treating this patient with concurrent chemoradiation? And are there some what is the workup that would what it would entail this patient who to decide his feasibility for concurrent chemotherapy?
Yes, Kana, but only one clarification for me before I proceed.
Yes.
Is there any strict definition for intermediate stage laryngeal cancer?
Uh,
Everybody's benefit.
Usually the laryngeal cancers would be divided into either the early cancers, which would be the T1 or the T2 N0 disease, and the T4 would come into the loco-regionally advanced. So we sort of would classify the remaining as the intermediate cancers, the T3 N0 or the N1 tumors.
Okay. Yeah, this is always in between for me. Yes, absolutely. Concurrent chemoradiation. Now, what would be the drugs? Before going into the drugs, I would definitely evaluate this patient. 64-year Indian is borderline geriatric. Some geriatric evaluation, finding out his fitness, how bad his diabetes, how bad his hypertension and cardiac status. Also, his audiometry would be very important. So if he's fit, at the end of it, single drug, that is one of the platinum compounds. Cisplatin is the drug of choice, where one uses according to your, depending on your experience, 100 milligram per meter day 1, 22, and 43, or weekly, 40 milligram per meter. Of course, there had been lots of literature and debate between 40 milligram and 35 milligram. We do start with 40, and of course, keep monitoring throughout the course how one tolerates it. It needs schedule modification, dose modifications, etc. If one is not cisplatin eligible, it's a toss-up between carboplatin, AUC2, or cetuximab. Which one is better? Difficult to say, but I was looking at a recent literature from US. Carboplatin seems to be somewhat better than cetuximab. So cetuximab seems to have become an outlier now for head and neck cancers. Not that it cannot be used. Those who are not eligible for chemotherapy at all, cetuximab can be used. So I do agree that concurrent radiation and systemic therapy for the gentleman.
One point on the CT here that historically we've been told that involvement of the pre-epiglottic fat would sometimes that is a radio resistant area because Dr. Agarwal, do you still have concerns with IMRT or are you happy treating with involvement of the pre-epiglottic fat?
I think, is it directed towards me?
Yes, sir.
Yeah.
Okay. That's the reason what I was trying to say, that it is undermined. The cartilage invasion is there many a times, which leads to its failure rather than it is a radio resistant area. I understand the fat is generally suggestive of advanced disease. So we will cover it very well, but the likelihood of a recurrence is high. Another thing, before I take this patient for chemoradiation, I need to know his habits and etc. etc. his dental status, and all those stuff, so that we should not land up in another issues. Like if he was a smoker, I would have ceased his smoking, rehabilitated him, and build up his chest. That even if he has small silent aspiration, we are able to take care of it.
Kanav, I think Kenrick is online.
Yes,
Is
sir.
he on?
Dr. Kendrick, any thoughts? Would you also agree with the plan?
Yes, I would agree with the plan. I think concurrent systemic therapy with RT would be definitely the best option for the patient in terms of laryngeal preservation. I certainly wouldn't jump to surgery unless if perhaps, as others have mentioned, there's a significant amount of subglottic extension. I do think a very careful examination in the operating room would be beneficial in that regard. I suppose the last option would be induction chemotherapy followed by response assessment, but I don't see how that would necessarily change our management in this case. And so I do think that a systemic therapy with RT would probably be the best option.
So I think as a message, I think a large chunk of these intermediate cancers, these T3, N0, N1 cancers, we would be happy treating with concurrent chemoradiation if the general condition of the patient allows him to do so. But in case you have a gentleman who's extremely frail, probably not fit for chemotherapy, Professor Shah, would you prefer to do a total laryngectomy on the patient, or would you treat
Well,
him only with radiation?
that's a $1 million question. And again, a lot of that will depend upon your discussion with the patient, your understanding where does he come from, what his profession is. I think in the olden days, the patient would have undergone total laryngectomy. But I think we are trying to run away a little bit from total laryngectomy as a primary treatment, unless the tumor is very advanced or there is a major cartilage destruction where we feel that the chemo radiation is not going to be helpful or going to hurt the patient and delay the surgery. Okay, so this patient is frail. He's not able to tolerate the chemotherapy, or his renal function is so bad that he cannot tolerate the chemotherapy. Again, I'm going to go back. I would be little reluctant to do total laryngectomy upfront. Would I treat the patient with radiation and see the response? Probably yes. In the olden days, before the laryngeal preservation program came in, we would have treated the patient with radiation therapy. And I think the radiation therapy group does a good job. What is the chance we'll be able to control the disease is little difficult to answer. But I have a feeling there is more than 60% chance we'll be able to control the disease with radiation alone.
Kanav, can I say something? Hello?
Yeah, go ahead, Devendra. I can hear you.
Yes, sir. So, sir, this is a very good question that sometimes a T3 cancer, if it is, you can't give CTRT, what next? Whether a laryngectomy or radiation alone. Now, by literature, we know that amongst the three, that is laryngectomy, CTRT, and RT has the most inferior control rates as well as larynx preservation rates. I mean, larynx preservation is inferior to CTRT, and control is a little poor. But many people, so this we have to go back to the patients, as you said, and ask them if they're ready for that little bit of trade-off to preserve their larynx, which is the chance of 60 to 65%. If that little trade-off in survival, which is maybe a little minor, are they ready for that trade-off? And you have to put everything into perspective. This patient has vocal cords mobile. There is
Correct.
there's a query involvement of paraglottic, query preglottic. So this is more of a mucosal disease of the supraglottis, glottis, and a little bit of subglottis. Cords are mobile, which tells you this is not deeply infiltrating. Now, this is a different lesion from a transglottic, deeply ulcerative lesion, which probably will not respond to radiation therapy. So, putting everything into perspective, that there is a superficial mucosal lesion. Yes, paraglottic and preepiglottic does upstage it, but it's probably a very minor involvement. We have not seen the scan yet, but it's probably a minor. So maybe radiation in this case would be better. So we can't put all T3s into one basket and say we will go with radiation if chemoradiation is not possible. I think we'll have to individualize the treatment and also takes patients, ask the patient if they're ready for that little bit of trade-off with only RT.
Very well said, Devendra. I completely agree with you. I think, when you see a patient with the intermediate group, as you mentioned before, Kanav, the first decision as a surgeon you have to make is what is the extent of the disease, what is the radiological finding, and what treatment is likely to give the best control of the disease. And if there is a other medical issues as you described, Kano, I think we have to go to the, if I don't want to use the word second rate or second class, but alternate treatment.
Dr. JP Agarwal, your thoughts, sir?
I really appreciate both my very senior radiation colleagues from the surgical fraternity. In a joint clinic, if this patient is ineligible for a systemic therapy, the best option is a native preservation of larynx with curative radiation. How do I tweak that radiation? Maybe I shorten the overall treatment time and increase the likelihood of a locoregional control in this patient. And especially for this patient is N0. See from the perspective, it is a mucosal disease, N0 disease. The likelihood of a controlled with accelerated fractionation with this modern technique, the chances of his controlling his native larynx is very good. And also without compromising the survival. And we will give him the best chance with that to have that. Maybe his voice will be probably not so great because of some edema for some point of time, because of the extensive mucosal disease. But I think over a period of time, he will benefit from that.
Oh, thank you, sir. Uh, So another thing that now that we are discussing the involvement of the paraglottic space, something that I would like to bring up is something that has been described by the radiologist as anterior paraglottic space and posterior paraglottic space. The paraglottis is divided into an anterior and posterior space by this line that is at the level of the tip of the vocal process of the arytenoid drawn perpendicularly to the thyroid cartilage. Dr. Chalker, sir, how does this affect your management, and do you routinely look for involvement of whether it's the anterior or the posterior paraglottis involved? Sir, you're muted currently.
I'm not sure whether you can hear that. We can ask Dr. Tam.
Yes, sir. Dr. Kendrick. Professor Shah, your thoughts on anterior versus posterior paraglottic space involvement?
I think it is probably a little difficult to evaluate that radiologically or clinically, but the picture you have shown is very impressive. the the problem with the anterior paraglottic extension is it goes very close to the anterior commissure, and that's where the role of the radiologist comes in. I think JP said it very well, that with appropriate targeting and appropriate dosing, they can get equally good control. So the problem with I'm not very sure that we do have a good data on the anterior paraglottic versus posterior paraglottic. There may be some data in the literature, but I'm not very convinced that we could separate it very well.
Yes, sir. So, what literature would say is that involvement of the anterior paraglottic space is still fine to clear surgically, whether you do that with an open partial laryngectomy, or you do it with some people would even recommend using the transoral laser for certain a subset of T3 tumors. And but
Well, if
once
you
the
talk
post,
about surgery, I think I completely agree,
yes, sir.
because it is much easy to do a partial laryngectomy for anterior extension because it is limited. The posterior extension, there's no limit to it. So I completely agree about the surgical excision. I think if you talk about radiation, I'm not very sure. However, the radiation oncologist would definitely like to target the treatment uh, portals appropriately.
Yes, sir.
Thank you, sir. I agree on that, sir. For us, whenever there is a posterior involvement, uh, especially the arytenoid area,
Right.
uh, what we have seen that even that small cartilage invasion, the likelihood, that's again I'm coming to that same cartilage issue, sir, or the joint issue, sir. People don't appreciate that movement of the cords throughout. Even a posterior, even if it is the movements are not great, there is always a likelihood that arytenoid cartilage is involved, and it will land up in a challenge. It works something like advanced T3 or akin to T4, sir. So we will
Yeah,
have more failures, more aspirations, even if we treat with curative intent of chemoradiation, sir.
agree.
So we'll move on to the second case, which was this young 22-year-old lady who had presented to us with complaints of hoarseness in 6 months. We have a photograph of her fiber optic laryngoscopy, which showed that there was a lesion over the left vocal cord reaching the anterior commissure with fixity of the left cord, but with a mobile arytenoid. There was a biopsy that revealed it was an invasive, moderately differentiated squamous carcinoma, and CT scan revealed a thickened left vocal fold with mild thickening of the left AE fold and infiltration of the paraglottis with an intact cartilage. Dr. Kendrick, your thoughts how you would like to treat this young girl?
Yeah, so with the fixation and the paraglottic involvement and anterior commissure involvement, it's a T3. I would be very hesitant to pursue surgery for this patient for several reasons. I believe, especially with the anterior commissure involvement, and I don't think she would be very amenable to a endoscopic laser resection necessarily. And so therefore, I would definitely refer her to a radiation oncologist for consideration of radiation as a possibility, possibly even with systemic therapy on top.
Dr. Chalker, would you agree with treating the young girl with radiation therapy?
Yes, yes. It's more of the disease. In the young girl, what I mean, why do you say it's a young girl, and how does the treatment differ? Is there anything else that you want to ask? Because this is clearly not a laser. Paraglottis is involved. It's going from anterior to very close to the arytenoid. You have to chop off the arytenoid as well. She'll do very well with chemoradiation. It's a proliferative growth. She will do very well with chemoradiation.
Would you consider her for an open partial laryngectomy, sir?
Hmm.
I would not. I would not consider with paraglottis involved for an open partial laryngectomy at this point of time. Because for a T3, with paraglottic space involvement, you have to add adjuvant therapy, right? So you have it's a dual modality therapy for this patient. So doing a open partial laryngectomy going into her laryngeal framework with paraglottic space involvement and then giving a radiation as is T3, I'm not so sure I would do that. I would rather give a chemoradiation.
Professor?
So now I'm concerned about 22-year-old. I mean, this is not a disease of young women. So there is something biologically or genetically very concerning. I mean, we see in our career 2, 3 patients like this, young girls, and some of them are very advanced laryngeal cancer who require total laryngectomy, and your heart goes out to them. doing a total laryngectomy in a patient below the age of 30 is very difficult. The same thing is going to be a problem here. And I'm more concerned, looking at the disease and the paraglottic extension, etc. If she fails our approach, chemoradiation or whatever you decide, then she will end up with total laryngectomy most likely. And I think we need to put this in our mind, in our heart, when we start treating these patients early on.
Kanna,
Yes, sir.
sorry I've joined late, but if I remember right, her paraglottis was very supple.
This imaging had showed some involvement of the paraglottic space, sir. It wasn't extensive involvement, but there was some involvement on the CT scan.
Paraglottis involved. Kanna, one point
Yes.
I wanted to make is we used to do open partial laryngectomies way back, and those majority of those got replaced with laser. And laser is more accurate. Though it is described in textbooks that you can do open partial with removal of the arytenoid, but with removal of the arytenoid, there is a good chance of aspiration. So I would be really wary of doing an open partial for this lady. As Sir said, if paraglottis is not involved, 22-year-old with microscope with laser, paraglottis is free. Then you may attempt the laser excision for this patient rather than open partial. I would favor laser over open partial. Otherwise, chemoradiation if paraglottis is involved.
The disease, when seen under the microscope, was the arytenoid. The disease was stopping well short, was short of the arytenoid, so that was not an issue. This girl, in fact, actually underwent an open partial laryngectomy. This was done by Pradhan sir in 2008. So she's now been on follow-up. She was staged as T3N0, and recently she did follow-up. She's been disease-free, disease is well controlled. This is her follow-up fiber optic that was done. We did not give her adjuvant treatment. She was only treated with open partial laryngectomy. This was a T3N0 disease.
Devendra, I'll just tell you that
Yes, sir.
I would not discount age. If for such a young girl in her early 20s to treat her with chemoradiation,
Right, sir.
when there is every likelihood that in time to come she will develop a second cancer. So I know that chemoradiation will treat her very well and will give her even better quality of voice than what this vertical partial laryngectomy has done. But I think age cannot be just ignored.
No, sir. It should not be ignored. It should be in the armamentarium of the surgeon. I was just a little skeptical because when it was presented, it was said paraglottis infiltrated. Now, if you have an infiltration of paraglottis, that is the little red flag for a vertical partial. Though you can do it because you take that half of the cartilage out. But certainly a point is well taken, sir, that it should be in the armamentarium of treating such young girls. Maybe if paraglottis is minor involved, maybe with laser also. Nowadays, with laser also, you can get a good control. Unless the paraglottis is infiltrated right up to the cartilage. But I would still stick my head if paraglottis involvement, sir. I would still go ahead with chemoradiation because now with the techniques you can re-radiate. God forbid she gets a second cancer.
I think, Dr. Pradhan, you have done a fantastic job in this case, but it brings up, when we are discussing a case like this in the tumor board, it brings up a variety of issues, including, I think, as Dr. Pradhan said, age of the patient, the functionality, extent of the disease, and what is your feeling as to the best choice of treatment. And, a patient like this, you have to look at her as, if she's my sister, what I want her to be done. And I think Dr. Pradhan brought up a very good point that he felt uncomfortable back in 2009 treating her with chemoradiation, which was a concern. And again, I think both Dr. Chokar and Dr. Pradhan are correct about the evaluation of the paraglottic area. This brings up the major issue that in all head and neck cancers, we need to put in perspective the initial evaluation of the extent of the disease, what will give the best functional outcome, and more important, the long term cure of the patient.
In this case, the best functional outcome will be with radiation therapy. There is no doubt about that. And the cure rates will be very good with chemoradiation, no doubt about that. The only concern is what will happen 10 years later when she again develops a cancer. You'll again give re-radiation. But all those things have their limitations. And I think that the vertical partial laryngectomy takes care of the paraglottic spread completely because the thyroid cartilage is resected. In fact, if you do transoral laser resection, the quality of voice will be much poorer because you end up doing almost a type 4 chordectomy and the voice quality is not good. But vertical partial hemilaryngectomy is not bad. This patient, very few indications remain for open partial laryngectomy. This, in my book, is still an indication for vertical partial laryngectomy. Very few indications remain. How many we used to do and how many we do now? Very rarely. Okay.
Dr.
Yeah,
Agarwal,
JP, yeah, JP should have the last word.
No, 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 sir. Thank you for coming in. And I really appreciate. I think in this patient, whenever young patients of 20s, 25 comes, we have to dig in the history very, very well. Any anything, the habits, the parents or the sibling had the similar disease. And now the perspective of HPV should not be ignored. Especially any young patients with no habits, we need to see these things also. And obviously, we need to go all out to do a best functional evaluation to get the best functional outcomes. That is paramount. And we can always debate 30s, 35, 22s, but to think about the second primary and not to offer something. So, my best foot will be the first foot to control the disease then and there. Whichever way, I think the patient feels comfortable. Sometimes I think 3 days treatment with surgery and out, great thing in comparison to 6 weeks and the late effects. So those dilemmas are going to be there for each and individual patient, especially young patients, both uncomfortable to the radiation oncologist as well as surgical colleague. But we should put all our mind in a joint clinic and then come out with a decision, sir.
Now, Devendra here.
yes, sir.
Dr. Pradhan, sir,
Yes.
just for my understanding, sir, open partial laryngectomy, I mean, laser scored over open partial laryngectomy because there was no interference with the laryngeal framework. And because
Very true. Yes.
we had a better voice. So, sir, for my understanding, after open partial versus laser, I thought laser would have a slightly better outcome because the cartilage is not damaged or resected. So the cartilage is there and the tissue heals with fibrosis, and the opposite cord then compensates. Or you can do some procedures such as fat grafting and so on and so forth to get a better voice outcome. Is that thinking correct, sir? That removal of laryngeal framework will have a slightly more inferior voice than laser?
If you remove the thyroid cartilage, the contralateral cord has a chance of abutting against the fibrous tissue there. But if the cartilage is kept there, there will be fibrosis. But if it's a type 4 chordectomy, if you've gone right up to the cartilage and resected it, then the opposite cord doesn't get a chance to abut against the opposite cord. And the voice is very breathy.
Okay.
It can be very breathy.
Right.
Very well done, Dr. Pradhan. This is remarkable. You should be, I'm sure the patient is extremely happy and you should be proud of her care and control over a long period of time. Keep in mind, you know, as Dr. Pradhan said, there are very few indications for initial partial laryngectomy now, and the technique and the expertise remains with very few people.
Yes, sir.
Very-
So there are, I think we all can agree that there is a small subset of patients where we may still consider doing an open partial laryngectomy even in this day and age of concurrent chemoradiation therapy.
Agreed.
So one other point that I would like to bring out is, since the last case had a fixed cord, is the difference between a fixed cord and a fixed hemilarynx. So this fiber optic laryngoscopy shows a fixed right cord but a mobile arytenoid, while the second video shows fixity of the hemilarynx where even the arytenoid is fixed. Dr. Kendrick, would you like to comment on the difference and how it would alter your management in any way if you're considering a surgical modality?
Yeah, these are very nice examples here. I'm not sure if it would necessarily alter my management. It would indicate to me likely that there's further involvement of the paraglottic space when there's a fixed hemilarynx. Do you mind playing the video on the first one again? On the leftist screen again? Yeah. Yeah, but I'm not sure if I necessarily would change my management. I don't know if others have thoughts about that.
Today,
Now,
Yes, sir.
you made an important point. So whenever, and this is for the juniors, whenever you do a fiber optic scopy, almost always document whether cord is mobile and cord plus arytenoid is mobile, or cord is fixed or cord plus arytenoid. Arytenoid fixity will tell you that the cricoarytenoid joint is involved by disease, and that takes away the option of any partial laryngectomy in majority of the cases. So if this girl's arytenoid was fixed, I don't know if that's fixed, that would probably take away the option of open partial laryngectomy. So only a cord fixity could be because of the weight of the disease, a little bit of paraglottic spread, but arytenoid fixity is almost always cricoarytenoid disease, which takes away the option of open partial laryngectomy. So this is an important point you're making.
Pradhan, sir, your thoughts?
yes, absolutely. But nowadays we don't do supracricoid partial. I won't say we don't do, but very, very rarely do we do a supracricoid partial laryngectomy. The patient on your screen on the left can be treated with supracricoid partial laryngectomy. The patient on the screen on the right side cannot be treated with a supracricoid partial laryngectomy. But we hardly do these. Both these patients will be treated with chemoradiation today and treated very well today.
Yes, sir. Point taken, sir.
Sir, I have something to say. So
Yes.
definitely you can go ahead with chemoradiation, sir. But see the bulk of the tumor, sir. So time and again, we see our response rates become lower because there is a sheer volume of this tumor. That is one. And the second, sir, they always have some sort of aspiration, either during the treatment or even after the treatment. Just like what you do uh, supraglottic surgeries for a partial laryngectomies, there is always a silent aspiration. And sometimes they are the cause of sudden death, sir. So we need to be very, very careful, very, very alert on those grounds, sir.
If he's a very frail elderly gentleman, then you would recommend a total laryngectomy. Is that what you're saying?
Yes,
JP?
sir. Yes, sir. So that will be a clean with least risk of aspiration or no risk of aspiration. So these patients have technically, they are laryngeal cripples, just less than a laryngeal cripple, sir. So a good job, artificial voice, and a good swallowing, and that will be much more beneficial in the short term as well as in the long term. We buy too much for this chemoradiation business and land up in having poor survival. That was just referred by Dr. Chokar in a passe. So we need to be balancing now. So earlier, the whole equilibrium was shifted towards everybody comes for chemoradiation. But now I think over the time, we should realize that, okay, which volume I will be able to control with 90% certainty in this group of patients.
I think that's why the first decision that the tumor board or the surgeon has to make is what is the best chance of controlling the disease with least complications. And as Dr. Pradhan mentioned also, when it comes to laryngeal cancer, we have to think in for future. Number one, the functionality of the larynx. Number two, the side effects. And as Dr. Jayaprakash said, issues about aspiration and the is it going to be a useless larynx? I think that's very important. And the last thing we need to put in the equation is what is the possibility this patient will require tracheostomy and whether we will be able to decannulate the patient. I think that's why the decision making in advanced larynx cancer is very complex. And one of the things at the tumor board or the surgeon has to uh, decide is initial laryngectomy the best choice? And I think that's where the discussion comes. Dr. Jayaprakash was absolutely right. There is this enormous paradigm shift or swing towards considering chemoradiation, under the pretext of larynx organ preservation. But are we doing it right to the patient? I think that's the bottom line. Keep in mind, uh, total laryngectomy after chemoradiation is not an easy problem. The risk of complication is much higher. The fistula rate is higher. Even though this has been described at an individual case, we don't think too much about it.
Absolutely. I think you said it brilliantly, sir. Thank you, sir.
We'll move on to the third case. This is a 63-year-old gentleman who came with complaints of hoarseness. He had no comorbidities. This was his fiber optic laryngoscopy. They showed that there is a lesion that is seen on the left cord involving the anterior commissure. This isn't a very good quality video. There was fixity of the right of the cord, but a mobile arytenoid. This is a photograph taken from the fiber optic laryngoscopy, showing this growth involving the left true cord extending superiorly to involve the false cord, involvement of the anterior commissure, and a fixed cord but a mobile arytenoid. The patient also had a CT scan, so I'd like to request Dr. Aditi to kindly help us read these scans and give us your expert opinion on how you would stage this disease.
So we can see a glottic lesion involving the false cord, the true cord, the false cord, the paraglottic space. You mentioned left cord lesion?
Right cord, sorry.
Right.
Yeah. So we can see lesion in the left cord, left paraglottic space. This is the true cord level. We can see the lesion in the true cord. So glottic CA, I'm going further down. I'm seeing it in the subglottis as well. These are the subglottic levels where I'm seeing the lesion in the subglottis. Also, do we have bone window images in this?
These are the images that we have.
Okay. Can you go to the previous slide? So on this, I can see that the right arytenoid is sclerosed. This is the arytenoid. I can see the fatty marrow on the left side. So right arytenoid is sclerosed. I would like bone window images to see cricoid and thyroid as well, mainly cricoid. But if not, I would call this as uh, a glottic CA with subglottic extension and arytenoid sclerosis, no extralaryngeal spread, no nodal disease.
Okay.
What is the significance of sclerosis of the arytenoid?
So on CT scan, we have um, 4 features which we use to give us an idea about cartilage invasion. One is sclerosis, the second is erosion, third is lysis, and fourth is lesion seen on both sides of the cartilage. So sclerosis is the first sign which we can see. It is a highly sensitive marker for cartilage involvement, but specificity is not very high. Also, for every cartilage, thyroid, cricoid, and arytenoid, the specificities of sclerosis are different. So, with high sensitivity, it is a marker that disease may be present, but there are higher chances of false positives also. But do we go ahead, and if we go ahead with surgery and don't remove this sclerosed cartilage, there is 50 to 60% chance that we are leaving disease behind.
Aditi, can you explain the role of MRI for better evaluation of the cartilage? And what is your preference, the fight between CT and MRI? Can you expand on that?
Yes. So firstly, CT is the primary imaging modality for laryngeal CA. Even for cartilage erosion, CT has a very high specificity ranging to around 90%. So we will, if we mention cartilage erosion or cartilage involvement on CT, that is, it is very likely that the disease is present, but there is a good chance that minor erosions and early cartilage involvement can be missed on CT. So usually after equivocal scans in CT or the times when we are doubtful about cartilage involvement is when we request an MR. So usually the only indication for MR is problem solving cartilage involvement and extralaryngeal spread. Now MRI has a very high sensitivity because even small mild signals on cartilage can be picked up on MRI. So sensitivity is as close as 90%, but the specificity drops down to 80%. Only and only because peritumoral inflammation and tumor invasion are the 2 things that we cannot differentiate between very accurately. So if, though with high negative predictive value on MRI, if a signal is seen on a cartilage, there's a good chance that disease is present. And it can then finally, in equivocal cases, it will be individual case and clinical context basis.
Thank you.
So, Dr. Chalker, how would you, what would be your approach to this patient with this sclerosed arytenoid? How does that affect your management?
So I'm speech swallowing. This is a functional larynx, no cartilage apart from sclerosis of the arytenoid.
Yes, sir.
There is no aspiration, I believe.
Yes, sir.
Yes. So again, this would it's a transglottic growth again.
Yes, sir.
A little worse than the first case that you showed because that was only a mucosal disease.
Yes.
This is slightly infiltrative disease. I will still go with if the patient is fit for chemoradiation, I would still go ahead with chemoradiation and organ preservation protocol to begin with.
So, since with the sclerosed arytenoid being reported, that would not alter your management in any way.
Sclerosis of the arytenoid, as of now, I don't think it has. It should alter your protocols currently. We don't have much information on that, but yeah, I don't think it will alter my protocol with sclerosis.
Okay, sir. Professor Shah?
Well, I think, this is the one case where we need to get to the entire extent of the disease. I think what Dr. Chokar said is correct. I agree with him that arytenoid sclerosis would not change my decision making. The whole idea of organ preservation is, can we preserve this functioning organ? Now, if the patient has difficulty in breathing, aspirating quite a bit, then we go back to what Jayaprakash said, is the primary total laryngectomy appropriate? And this is where the decision making comes. Is this patient likely to be benefited? And there is a good chance we will be able to preserve the larynx. Probably more than 50% chance we'll be able to preserve the larynx. So I completely agree with Dr. Chokar to go with chemoradiation. Now, this is one case where not only the decision making initially, but the long term follow up by the same individual is very critical. The worst thing you do in this case is you treat them with chemoradiation, you miss the appropriate follow up, or do not appreciate the recurrent disease, and then they come with a massive paraglottic disease which is incurable. That's where we miss the boat.
Dr. Agarwal, sir, would you agree with the treatment?
Thanks, Aditi. I think it was very important to suggest that we should see this CT scan in all the three uh, sagittal as well as coronal cuts, especially about the subglottic extension and the sclerosis of the arytenoid. So we have reported in the literature, there is no doubt that I will treat this patient with chemoradiation, airway is intact, can speak well, has no aspiration. At this point of time, seems a functional larynx. But any posterior invasion, especially when the arytenoid is involved, the outcomes of chemoradiation are on a lower side than a routine. And we have reported in our literature, and we have said it, not with only a CT scan, but with the newer radiomics technique. The entropy is high in this group of patients, and they are likely to fail locally. So, as Dr. Saha said, long term sustained follow up is essential so that you pick up this group of patients for early salvage. And they should not, we should be very, very careful for silent aspiration in this group of patients. Posteriorly, the saliva trickles, so any fever should raise a cause of concern at any point of time, even during, after, and long term follow up.
Kendrick, any comments? Maybe we can ask Kendrick what he thinks.
Um, no, don't have anything much more to add. I agree. I'd probably start with chemoradiation first.
Kanav,
Yes, sir.
Now the question that you asked for the first case is probably more pertinent here. In this case, if the patient is unfit to take concurrent chemoradiation, the choice that you have is radiation alone, plus minus biological, but if they can't take because of poor renal function, versus total laryngectomy. I want opinion of the house. Now, in this case, what would you do now?
Devendra, you are very smart. When the problem is difficult, you throw it to
If
other
he's
people.
unfit for
Professor Shah.
chemoradiation, then
Pose the
he's.
question. I don't have to give the answer.
I will take it. I will take it. What I think I think Dr. Sekia will be able to enlighten us on the basis for the chemoradiation. But definitely, again, I don't see nodes here. That gives me an insight. Go ahead with curative radiation in accelerated fraction. That's Devendra, that's what I am trying to push that. So a mucosal disease is there, not in a supraglottic area, a glottic as well as a minimal subglottic, what we can see from that coronal section also. So I think I will try my level best to treat this patient with my, at least with curative radiation in a shorter fractionations.
Pradhan sir, would you be happy just treating this patient if unfit for chemo with just radiation therapy, or would you prefer a laryngectomy?
Laryngectomy. Laryngectomy would be better, I think.
Okay.
So, Kanav, let me be the devil's advocate. We are pushing chemoradiation, and if can't give chemoradiation, radiation with that organ preservation protocol. We all forget that the organ preservation protocol had a 6% detriment in survival. And it has never been proven in any studies that is equivalent to total laryngectomy. It has never been compared head to head. That was not the endpoint of any organ preservation study. And we try to fit it for all the lesions. For lesions, as I said earlier, which was the case one was superficial, mucosal, cords were mobile, minimal pre-paraglottic. Yes, radiation alone with altered fractionation, Dr. JP would do well. A deeply ulcerative T3, please do not give up total laryngectomy. Today, with tracheoesophageal punctures, a clean total laryngectomy, you can rehabilitate the patient well and have a decent quality of life. A failure of a radiation therapy to do a salvage laryngectomy is extremely difficult, has increased complications. So do not just jump onto organ preservation. Okay, if not chemoradiation, just radiate the patient. No, please look at the tumor. Deeply infiltrative, transglottic tumors, they're not going to do well with subglottic extension. We know they're not going to do well with radiation therapy. Keep total laryngectomy as a treatment decision when you're looking at your joint clinic.
As the gold standard.
Absolutely, sir.
Very well said, Devendra. I think everybody will completely agree with you. You know, I just want to go back to the history. There was always a question when the chemoradiation came, organ preservation came. We were on the bandwagon of organ preservation, hoping that we'll be able to preserve the larynges. But remember, if you don't choose the right patient, as Devendra said, you're going to hurt these people more. Doing a salvage laryngectomy on these patients is not easy. It is difficult. I know some 20 years back, the Europeans always looked at total laryngectomy. They used to call that mutilating operation. And I remember in one of the international meetings, there was a lot of discussion about total laryngectomy being a mutilating operation. And I had to make a comment. It is not a mutilating operation. It's a mutilating disease for which we are doing the right operation.
Correct. Very true.
So this patient, in fact, after it was discussed in the tumor board, like Dr. Agarwal sir pointed out, concerns with the infiltrative nature and higher chances of failure. The decision that we had come to was to consider this patient for induction chemotherapy as he was in good general health. So he had induction chemotherapy. He was symptomatically much better. Voice improved. As we can see, the cords are now better mobile. Imaging wise as well, there was a good response to treatment. So then he went for definitive treatment with the organ preservation protocol. Saikya sir, what would be your views on the use of neoadjuvant or induction chemotherapy in laryngeal cancers?
So in a given individual, you never know what might happen. And that's the true example in this case. You can discuss a lot. You can discuss a lot in your tumor board. At the end of it, probably the shared decision making. And then you go ahead. I think we have so much more to know about the tumor biology. And then what you call microanatomy, because we are still deriving from what you get to see in with your laryngoscopy and MRI, PET scan, whatever I do. There's probably much more to it. And we don't know who would respond to induction therapy, who would not. At least what we know that majority of the cases, we don't get complete remission. So I think that's very important. Any tumor we treat, if we can get a complete remission, that will prognostically very important. But very happy to see that induction therapy has worked in this case. And yes, induction therapy, meta-analysis has shown that definitely it does work, carefully selected cases, and probably it was one of those cases. And yes, we do discuss a lot with patients. For me, it's always shared decision making when we sit down in the clinic. Tumor board is tumor board, that's for the doctors. But the shared decision making is where I think we really come to treatment when number of treatment options are open. Usually induction therapy is usually we do use in the cases where patients are very symptomatic, they need a quick relief. We know that study with that one tax 3-3 and 3-4 have shown that if you get induction therapy, 3 drugs versus 2 drugs, so 3 drugs have done well. So yes, there is definitely a role for induction therapy in carefully selected cases.
Thank you, sir. So I think broadly, if you were to list out the indications of induction chemotherapy in laryngeal cancers, there would probably be one when there is doubtful cartilage involvement, where we aren't sure whether there is involvement, either there is involvement by tumor or there is it is the inflammation that is leading to the signal in the cartilage. Two would be a case with where it would be staged as a T4, but there is exolaryngeal spread through the membrane rather than through the cartilages. And probably in a bulky tumor where we would like to downsize the tumor prior to starting him on definitive chemoradiation therapy. So I think these are probably the three indications you would consider giving the patient induction chemotherapy. Chocolate
Or
sir, would you agree with that?
or kind of patient is
Kanav,
extremely total
sorry.
laryngeal
Yes.
and wants to see, and you want to see whether there is some response with induction chemo, and then proceed with the final decision.
So, yeah, Kanav, I think to bring in more confusion here, based on your keynote 689, what should we discuss about this case? This case, I know it's an operable case, and 689 shows that you give induction therapy with doublet, chemotherapy doublet plus pembro. And then, of course, majority of the patients have undergone surgery, then radiation plus pembro and maintenance pembro. I think we need to discuss more. I'm not suggesting that we should be doing that, but it's coming into our daily practice now. These kind of cases, will they be candidates?
But
Right, sir. Kanav, first time induction after all these trials, first time ever induction has shown event-free survival benefit in operable head neck cancers with pembro. But early days, it's Dr. Saike, if I'm not mistaken, it's 3 cycles of chemo plus pembro with 15 cycles of pembro, 12 more cycles of induction pembro, which is a total of 15. Followed by maintenance pembro. I don't know how many of our patients currently would follow that schedule. But yes, exciting and exciting data coming in, and as we go more ahead, we will go into that NACT data. Kanav, your question of one comment I wanted to make is exolaryngeal, and all of us think that exolaryngeal shrinking the disease, we can then try and give CTRT. But there was a small analysis, and Dr. Shiva has published it from the Tata Hospital, that T4B disease, which is T4 disease with not B, T4 disease, which is exolaryngeal and or cartilage erosion, surgery scores better over organ preservation protocols. So I don't know whether it's published it, but I think if I can find it, I will send it next time. But I think when they analyze the results, and all of us in the joint clinic think that, shrinking the disease, the exolaryngeal component, we will then be able to go back to organ preservation, which probably may not be true. So that is an area I would, be a little skeptical about. Again, induction, I would more use it for hypopharyngeal cancers than for laryngeal cancers, unless I'm unsure that this patient will do well with CTRT. Then I want to look at the response, or I want to select my patient, or bioselect, as Dr. Saikia said, the biology. I want to look at the biology. If this patient is going to respond to NACT, a higher chance to respond to radiation therapy. So that is the only small subset of patients I would try NACT. Otherwise, majority of the cases, NACT is for advanced hypopharyngeal cancers rather than laryngeal cancers. Dr. Shah, your comment?
No, I was just going to ask Kendrick. He's probably more involved with the Pembro. Kendrick, any thoughts about the current role? Maybe you can expand the Pembro to the whole head and neck squamous cell carcinoma family.
Yeah, we at MSK at least, we haven't been using a lot of neoadjuvant chemo or immunotherapy for laryngeal cancers. I think primarily because uh, it often would not alter the surgery significantly itself. Although with 689, one can now make the argument of improved event EFS. But in terms of other head and neck squamous cell carcinoma subsites, especially oral cavity, we've certainly been running trials currently for cemiplimab as well as other immunotherapies of induction, followed by like a response adapted surgery to decrease the morbidity. For example, altering a total glossectomy to a hemi or a partial even, or taking a marginal mandibulectomy and avoiding that. Those are pretty common examples that we utilize that for. And there are arguments to be made as to whether sometimes we combine with cytotoxic agents and whether that is primarily the driving factor versus immunotherapy. But I certainly think it's an area to explore currently, especially with this new 689 data.
Dr.
Thank you.
Agarwal, your thoughts on?
So this is kind of to you as well as to Devendra and Dr. Saikia. So in cases of there is a obstruction in the hypopharynx or in the larynx, do you use something like NACT to avoid a tracheostomy? I think there are some reports from TMC.
I think we have been doing it.
Sorry, go ahead, sir.
We have been doing it in selected cases.
So I think that is an important area, especially in context of ours, and especially those patients who can afford it with this immunotherapy. I think that needs to be seen in our context, sir. Because any tracheostomy pre-laryngectomy will increase my ports as well as are the important issues for local recurrence, especially stoma recurrences.
Sir,
Any thoughts?
a word of caution on NACT for stridor. NACT for stridor is okay for those proliferative lesions of the supraglottis or glottis, which are kind of obstructing your this, and you want to shrink it a little bit to tide over that and prevent a tracheostomy. Far and few cases have to be monitored well. For deeply ulcerative tumors, which are stridor is one of the indications that it's not a functional larynx. So unlikely organ patient preservation protocol. So only the proliferative, which is causing the ball valve effect or obstructing the inlet, giving rise to the early stridor, you can try induction chemotherapy. Otherwise, I would not go down that route as an indication for induction.
Yeah. I completely agree with that. Proliferative lesions, like they respond pretty well to a couple of cycles of chemotherapy, but stenotic or fibrotic lesions, they don't. They have different biology. We have seen it in esophageal cancers as well. So careful.
So a cheaper way of debulking them through laser or something, will it not be a cheaper way?
Certainly not the hypopharynx, JP. Maybe the larynx, yes. But like Devendra said, only if it's an exophatic bulk that is blocking it, then transoral laser resection can be done to avoid a tracheostomy. But not if it's a stenotic.
Okay.
Stenotic.
Yeah.
And
Agree, sir.
certainly not for the hypopharynx.
Okay.
I think we also have Kanan sir who's joined in. If we can have his thoughts on the role of neoadjuvant chemotherapy to prevent a tracheostomy in a patient with stridor. Okay, I think there is a issue with sir's audio. We'll move on to the next case. This was a 43-year-old gentleman, shopkeeper by occupation, came to us with complaints of hoarseness in 6 months and stridor since the last 3 days. This was his fiber optic laryngoscopy. If Aditi could help read out these scans for us?
Okay, so I can see a bulky tumor in transglottic tumor involving the left false chord, left true chord, paraglottic space. This is a superior section. We can see that involvement of the paraglottic space. And inferiorly, we can see the involvement of the subglottis as well. So transglottic tumor with paraglottic spread and yes, definite bony erosion, bony lysis in fact. We can see these are the bone window images. We can see the right arytenoid, the left is completely lysed. And in the subglottic region, there is also lysis, erosion of the cricoid cartilage. So transglottic tumor, paraglottic spread, cartilage erosion, no exolaryngeal spread. Yes. No obvious nodal disease I can't see in these sections.
So this would be a T4 tumor. Kanan sir, how would you like to manage this patient?
Uh, it's a
43-year-old gentleman with cartilage erosion, erosion of the cricoid cartilage with mild stridor.
this is direct laryngoscopy, total laryngectomy.
Okay. And what about if the patient comes to you in stridor? What are the precautions that you would consider? What are the tips that you would give us when we are considering doing an emergency tracheostomy?
Actually, it's better to do the surgery in one shot if you can go through without a preoperative tracheostomy. But if you're forced to do the tracheostomy, then of course the standard teaching is to have a high tracheostomy. But the thing is that the incision should be in the same place. It's only the cut of the trachea which ought to be high.
Yes, sir.
I think, just an editorial comment. When the patient comes with advanced laryngeal cancer and airway problem, there are a variety of issues that come in the discussion. What is the right treatment for his laryngeal cancer? That's the most important. And as everybody agreed, this patient requires a total laryngectomy. He has been having stridor for 3 days. Can we buy few days without doing tracheostomy, keep him in the hospital, give him steroids? We're just trying to buy the time for the optimal surgical procedure. At Memorial, at once upon a time, this was about 3-4 decades back, there was a strong indication for doing emergency tracheostomy. I think that is a little bit difficult for the surgeons to come over the weekend and do emergency tracheostomy. Emergency laryngectomy. Should we try to avoid tracheostomy? All cost. I think we should try to avoid tracheostomy. If the patient and the family understand and they are agreeing for laryngectomy, we should schedule the patient for surgery in the next available operating room. Till then, by the time, with whatever conservative treatment. The last thing that we need to discuss is, can we open the airway with laser instruments and debulking the tumor and give a better airway to avoid tracheostomy? I think that's the bottom line. Unless the patient comes in the emergency room or has severe airway distress that you think you are going to lose the patient in the next few hours, I would try to avoid tracheostomy as best as possible.
So I think we agree that this patient needs a total laryngectomy. So Dr. Chokar, sir, your comments on the closure of the pharynx. When would you like to close it primarily? When would you need a patch? What technique would you use?
So, a transglottic growth, purely a laryngeal disease, majority of the times will undergo a primary closure. If you have a pharyngeal involvement and you're not getting adequate mucosa, then you put in a patch. Now, there's various stretched versus unstretched mucosa, whether it's 3 centimeters, 2 centimeters. It's a decision that you make on table. And nowadays, with good plastic reconstructive techniques, the threshold to put in an augmentation patch has gone down. If don't do the key is don't do a tight closure over a Rein's tube. That's going to leak. So if you have excised the partial pharynx, then better to augment that mucosa with either a free radial or a PMMC or whatever technique is available there. But a glottic disease measured the times with no pharyngeal involvement will undergo a primary closure.
I completely agree with Devendra. I think the only time we're concerned if the patient had a previous radiation and you are doing a total laryngectomy, even for laryngeal cancer, you are a little bit concerned about the mucosal edema and the closure, which may not heal very well, and the patient may end up with a minor fistula. Remember, a majority of minor fistula, minor leak, but that is not clinically symptomatic. They will override that very well. But if the patient had previous radiation therapy or chemoradiation therapy, the closure is very concerning, and that's where I think, as Devendra mentioned, you may consider either a muscle flap or even a free flap to support the pharyngeal mucosa.
Right. It's actually been our practice at Memorial now for patients who are going to be radiated or have previously been radiated, even if the pharynx closes primarily, we oftentimes now place a adipofascial ALT flap over the uh, over the closure just to bolster it, decrease the rate of leaks, as well as potentially, decrease the complications from radiation afterwards. Although, we're still running the study, I don't believe we have any data, but at least clinically it appears to be beneficial for the patient.
I think I agree with Dr. Tam that prevention should be done at cost rather than to face, because this patient will certainly need adjuvant treatment, and to give adjuvant treatment in the correct time is of a paramount importance. So I think flap is a great idea.
Kendrick, you want to expand on the free flap ALT or just the pectoral muscular flap?
Sorry, sir.
Yeah. Yeah, we favor the adipofascial ALT at MSK just because we have a lot of plastic surgeons around who are able to do it and quickly and efficiently and without complications. And in terms of the donor site morbidity for the patient, it's quite minimal. And in terms of the success of the adipofascial, the complications are quite low, even if the flap were to fail, which happens very rarely. It is still a buried flap in many ways. And so, I think clinically, at least, it seems to have decreased the rate of fistulas post-operatively, but also post-radiation as well. I have quite a few patients that I've inherited from, my predecessors patients who have unfortunately developed fistulas because, the pharyngeal closure is just underneath the skin. And so there are many weak points that can occur after radiation that could result in fistulization.
Kanav, can I come in?
Yes, sir.
So, Kanav, post-radiation is a different ballgame altogether. We were talking of per primer. Post-radiation, I agree with Kendrick that we will always augment. If you get a primary closure, always augment it with a pectoralis myofascial flap. The question again here is, if in a post-radiation, if you need to augment the pharynx, if you're not getting a primary closure, many think that a radial, and this is just my experience, a radial with a very pliable flap, and it folds very well, and you can do a patch with a radial very well. But I prefer in the post-radiation setting either an ALT or a pectoralis major flap, for the simple reason that it carries its muscle with it, and you can cover the muscle to the prevertebral fascia and cover your carotids. A leak from a radial straight away will go on the stump of your superior thyroid artery, which is ligated on one side. But with having muscle there gives you that additional security in post-radiation. This is just my thinking. If it is a post-radiation patch that I have to put on a pharyngeal mucosa, I would rather do an ALT or a pectoral space rather than a radial. But the radial looks very good. It's a thin, pliable flap for per primum setting. Excellent flap to do if you have less pharyngeal mucosa.
I actually agree with that entirely. I think the ALT actually provides better bulk, more tissue coverage, and like you said, the vastus muscle that comes with it is beneficial in terms of covering the carotid. So I agree. The times that I have seen issues are with the radial forearm because it is pliable, but it also just doesn't provide as much coverage of surrounding tissues.
And in the post-radiation scenario, they are going to shrink. They are going to have some fibrosis. So it's always better to have a good amount of flesh there.
How do you manage a leak?
I think we can have Kanan sir's thoughts on this since
Go
he's
to the church and pray.
Yeah,
No,
pray. Exactly.
but I think the management of leak is very complex. I don't think we can talk much about it in the conference room. But just to summarize, you divide it into two. Is it a minor leak that you can potentially wait and see what happens? Uh, is the patient previously radiated? That's very important. The second thing is, did you use some kind of augmentation closure? Was the closure under tight regime, were you unhappy at the end of the operation? How did the mucosa look? I think those are the important issues. If it is a minor leak that you demonstrate only radiologically when you do the gastrographin or barium swallow, but clinically there is no major problem, I think most of those will close in another week or so. Just keep them NPO and you will be able to see the good results as long as the wound is not getting infected. The problem comes either the wound gets infected or there is a pus under the skin or there is a big fistula. Those are some of the most difficult problems. Not only difficult for surgical correction, because whatever you try to do, you make the fistula bigger. You bring them to the operating room, try to put something, it doesn't help much. The best option at that time is continued monitoring, observation. You need a treatment team who can take care of the fistula, irrigate the wound, do the packing appropriately. The major concern in these cases comes, am I going to have carotid blowout? I think that's a major concern. And I think that is something that you need to be very careful. The critical aspect of infected wound is open it wide, let the pus come out, let there be no necrotic tissue, debride the patient. If you need to debride, bring to the operating room and do the best job. But fistula after total laryngectomy, a major fistula is a real problem.
Just to add to that, sir, besides the points that Dr. Shah has made, another point that we look at is whether it's an early or a late leak. If you have a leak very early, it's probably a technical failure and you need to go in early. If you have a late leak, then you classify it as minor, major. A major leak with potential of hemorrhage, as Dr. Shah said, is where you would go in. So, early leak, a leak which is potentially threatening to cause hemorrhage. If it's a post RT and you have not put a patch in the first instance, these are the few indications that you'll go in early and take the patient to the operating room. A small leak, a well contained, a well lateralized leak, a late leak, which has happened after 10 days, 11 days, you can conserve it. Usually, it will go down with time. A major leak, not settling with time, you'll have to take it to operating room and augment the mucosa.
Dr. Agarwal and Dr. Saikia, your
So,
opinion on
any percentage difference between MSKC and Indian scenario about the early leaks, late leaks, major leaks, minor leaks?
Kendrick, you can make a comment, but my comment is it's probably same. It's a surgical issue. I completely agree with Devendra. As he said, I think he made a very passing comment that the leaks are surgical issues. But remember, it's not just a surgical issue, it's a decision making why we did what we did. And that's where the role comes. If you are, especially if you are not doing primary laryngectomy, it is secondary laryngectomy, you need to be absolutely sure at the end of the procedure that you have done a satisfactory closure to avoid any leak. In spite of that, I would say there is 15 to 20% of the patients after radiation who will develop leak, and about 5 to 10% will develop a major leak. Kendrick, you have any comments on that? You have seen quite a few of these.
Fortunately, not my own yet, but I'm sure they will come. Um, yeah, post-radiation leaks are very, very challenging, I would say. And when that happens, I'm managing two currently. Um, and I tend to take a very slow approach as long as I feel that there is, fortunately, the two that I'm managing don't have the potential for carotid just because they're quite midline, I hope. And so then it comes down to, what can we do to help close the fistulas, the cutaneous fistulas, as best we can. Oftentimes I'll place the salivary bypass tube to see if that will help and leave it in for several weeks as long as the patient can tolerate it. And then the other thing I've also noticed is that esophageal dilations, or sorry, esophageal stenosis below the level of the leak is, I find, often the cause of these. Um, because there's a buildup of saliva there, because it just cannot pass down. Um, that exasperates the leak. And so, either myself or referral to a GI specialist who will carefully do an esophageal dilation is important. Um, that being said, doing a dilation can also significantly worsen things as well. Can cause rupture, can cause infection as well. And so these things need to be done very, very gently, but very challenging. And then I think um, there's a want by the surgeon to want to jump into doing another surgery to close the fistula. But I think taking a slower approach is often more important to see if more conservative measures can be done.
To Dr. Tam, do you use hyperbaric oxygen? One, and
Actually, yeah,
glycopyrrolates.
I don't use either actually. I Hyperbaric oxygen probably more from a logistical standpoint is challenging, and also I haven't seen it be helpful. And so I don't regularly recommend that. Glycopyrrolates, I actually do not do. I find that the tachyphylaxis afterwards can be challenging. I found that also most of our patients are older that need the laryngectomy, and so it can cause quite a bit of sedation or mental confusion as well. What I have done actually that I found useful is Botoxing the submandibular and the parotid glands, and doing that every 3 months. Actually, I find that drying up the secretions, as long as the patient can tolerate it, I find that the Botox actually helps the best without the side effects of glycopyrrolate.
Thank you.
Carotid blowouts are a thing of the past, Ashok. We don't see
Oh,
we don't see carotid blowouts now.
if you think that this patient is likely to go and develop carotid blowout, the best thing is for me to go to India for 3 weeks and come back. Let somebody else, Kendrick, manage the patient. It's a real difficult problem. Let me just go back to Dr. Jayaprakash's question about hyperbaric oxygen. The issue of hyperbaric oxygen always comes up, whether it is osteoradionecrosis of the mandible or the wound problem or pharyngeal fistula. For whatever reason, I can't explain exactly, it has not become very popular with Memorial. Memorial does not have a hyperbaric center. In New York City, there are 2 or 3 centers, but they use mainly for wound problems, the wound necrosis or the breast issues, but very rarely for the head and neck problems. One of the concern we have, if the patient has very advanced cancer and you have done the surgery, We are concerned about the recurrence of the tumor on hyperbaric oxygen. I think we have seen that in oral cavity cancers. The tumor grows in front of your eyes. So keep that in mind before considering hyperbaric oxygen. It has not become very popular in memorial.
Kanna,
Yes, sir.
how does the leak announce itself? S- Students need to know that. How does the leak announce itself?
So there are various signs and symptoms that can pick up in the patient. It can start with if there is a drain in, the drain color may change, the quantity may increase, it may be foul smelling. The patient may develop a fever, may have some tachycardia, and you may also see some discharge from the suture line. And also the patient, if there is a leak that is into the stoma, the patient may also complain of an increased cough. So these are
Very,
signs.
yeah, very often you go into that room and you find that patient is coughing a lot. He's coughing because he's aspirating. The leak is directly directed into the tracheostome. Then you'll find that there is a foul odor when you enter that room. You don't want to go for rounds in that room. So these are the two things. Later on, you will get in the drain, it is turbid. And my own feeling is that once you know that there is a leak, it's best to go in and take corrective measures. A lot of these patients will need postoperative radiation therapy, and you sit in the hope that this will close. It'll take a long time to close. So often the leak is directly at the level of the base of the tongue, where you close the pharynx and the base of the tongue. And that fistula takes a very long time to heal. So it's better to intervene early, find out where the leak is, and 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 cover it after suturing it, cover it with a flap, and give the patient the best chance of. One of the things that I wanted to ask Kendrick is when you put an ALT flap, does it not hamper the tracheostome with a huge bulk coming above the tracheostome and almost occluding it?
Yeah, definitely. That can definitely be an issue. The patients will often look like a bullfrog afterwards, to be honest. We do some debulking of the ALT as well, which can itself be risky in terms of compromising the vasculature of it. That's often how we deal with it. But I find that after about a week in the hospital, that the ALT has already shrunk by about 30% or so, and a lot of the swelling resolves itself. So I haven't had any issues specifically of it being so bulky that it covers the stoma, but it can definitely be quite bulky sometimes.
Very,
Karna,
very often I've tried to find out what is the acceptable leak rate and what is the leak rate that we have in good centers like the Tata Memorial, like the Memorial Sloan Kettering. And very often in these conferences, when I used to attend conferences, I don't anymore. I would go and sit next to somebody, an authority, and I would talk to them, and then I would ask them, what is the leak rate? And the topic immediately changes. They immediately go to some other topic.
Sir,
When you
can
don't
I
want to
comment, sir?
tell your correct answers,
Yeah.
which the
Sir,
subject.
Agarwals are there, JPs are there to blame, sir. So don't worry, sir.
so,
So, sir, can I come in? Devendra here.
Yes,
Sir, really, after all these years, we have every theory, nutrition status, hemoglobin, SOR, closure, everything. But I have not understood which patient will leak. You do the perfect closure, you're happy at the end of it, it leaks, and you do a bad closure, it doesn't leak. I mean, you think it may be a tight closure, I should have put in. I really don't know which patient will leak. So I don't know about others, but very, very difficult to say. As you correctly said, world over the leak rates, I think, are the same because we don't know which patient is going to leak.
But you always used to phone me, Devendra.
One of the things I learned when we used to do total laryngectomies late in the afternoon, you finish the case at about 7 o'clock, And you say, okay, let me just close primarily, hope it will be fine. And then the patient ends up staying in the hospital for 2 months. And then you look back and say, gee, it was 7 o'clock. I should have done it. I would have stayed in the hospital till 9 o'clock. And now the patient is staying in the hospital 2 months more. I think this is a learning curve. It is something that your experience tells you, and that's why we always say the good judgment comes from experience, but the experience comes from bad judgment.
I keep telling Kannan, please re-explore. If you find a leak, just go in and please correct it. Do something. Don't wait on it. Sometimes he agrees, sometimes he doesn't.
So do you think, sir, we need to have a nice chapter in any of the books on the leak itself?
Yes, yes. Yes, I think we need to. We need to give our students some direction. We need
Thank you, sir.
some direction. Good suggestion, JP.
Kind of a bit of medical oncology opinion here, as you asked. I was a young man, bad disease, and we have already talked about the kind of complications he will have only after even after surgery, acute and delayed. JP will give radiation. As a medical oncologist, probably I'll be extremely reluctant to get chemotherapy and make his life more miserable during the treatment. And that would be my opinion. I think I will try to convince my colleagues and patients that please avoid chemotherapy. Probably as medical oncologists, we might not be able to aid anything to these patients in the long-term control. Forget about a cure. I think these are we face every day in our practice, and the tough questions probably we should try to discuss and take a final call, because most of the medical oncologists I get to see in the country, they end up giving chemotherapy, and patient goes through a very, very miserable course during the treatment. Literature is okay in its place, but in individual cases are equally important. JP?
Sir, there is a question on the chat box.
Yes, there is.
You want me to read, sir?
Yes.
Now, there is a role of endovac therapy in managing PCF leak. This question is from Dr. Praveen KK.
Any comments? I do not have any experience using the endovac therapy, but if Dr. Kendrick or Dr. Chalker have some experience.
I have not actually. I've not tried that. I've actually thought about doing it for a patient before, but unfortunately, no experience. Is the endovac the one that's placed intraesophageal? Is that what he's referring to?
No, no. I think it means negative pressure dressing, the one which
Oh, okay,
we use for
just the
the plastic
external.
surgeons
I
use
haven't.
the closed
Yeah,
negative
I
pressure.
haven't. I always worry about it just drawing more saliva through. And just formalizing the fistula more by, causing increased granulation along the tract and potentially epithelialization. So I worry about that. I prefer to just stick with the packing.
So Kanav, as Dr. Pradhan said, if you have a leak which is a per primum case and you want to start radiation, if it's a major leak, if it's a leak which is detected on radiology, you can wait. But if it's a clinically detected leak, an early leak, unlikely it's going to close very soon. And then this endovac, you have to go in early. Endovac sometimes may be used for post radiation, but we have not used it very often because we like to irrigate the wound, keep it open so that there's no collection below which can threaten blowout. So laryngeal cancer, I'm not sure we have used. At least I have no experience of using it, but I'm a little wary of using it. One point that I want to make when we are talking of leaks is, over the years, as I said earlier, the indication of putting a patch or augmenting the mucosa has got down, and that probably has led to a little lower read rates. Earlier, we used to, stretch the mucosa. Oh, this is okay, 2.5, this is 3, this will close. If you have resected a part of the pharynx, I think it's a good idea. Well, I have there's no literature to this, but I think it's a good idea to augment it. Getting good tissue rather than closing it tight is one point that I would like to make. Rather than closing it tightly, better to augment, because plastic surgery has now really improved and we have plastic surgeons available. So one thing that I've changed in my practice over the years is decrease my threshold for putting in a patch or augmenting the mucosa.
So
When do you
apology.
start, when
Sorry.
do you start feeds post-op for a laryngectomy? When do you start oral feeds? Oral feeds.
This is a good question, Sultan. And there is always a debate when you want to start the feeding. The only reason I'm picking up this question is, as a surgeon, you want to wait for 7-10 days. It is not uncommon in a practice the gastrographin or barium swallow, make sure there's no major leak. But that is for the major leak. The minor leak will be very difficult to identify. Jesus Medina, the chairman in Oklahoma, who is now retired, would want to feed the patient with liquids 48 hours after surgery. And his rationale was, I think it is something to think about, that you produce 2 liters of saliva every day and you are swallowing that anyway. So what does it matter giving 500 cc of liquids by mouth? I think that is a good thought, good discussion point. I don't think as a surgeon who is worried or fearful of fistula, we would want to do that. But I just wanted to put it up. Is one of the most leading head and neck surgeon in the country, and he would do this within 3-4 days. He has written a paper on it. The name is Medina, Jesus
Yeah.
Medina.
Right, sir. So there are a lot of papers after that as well, and there is direct comparison of early versus delayed feeding, and
Yeah.
they have shown difference in the leak rates. Now, while that is true, sir, we are a little hesitant in starting, and as you correctly said, there's a 1.5 2 liters. But my only fear is that swallowing saliva is kind of an involuntary movement that we have been doing since childhood. Giving sips and moving the tongue is a voluntary movement that you induce in a patient, which may lead to the movement of the base tongue. It's not scientifically proven, but that's why I don't start my feeds for 10 days. I may be wrong, right? The literature, the small studies for the students, if you have to answer this question in your exams, studies have shown that there is no difference in the leak rates for early versus delayed feeding. But majority of the centers in India, at least I know, will wait for a week, 10 days before initiating oral feeds. So
The
when do you
same.
start?
The advantage they feel giving oral feeds is that the mucosa inverts as you swallow the mucosa inverts, which is what surgeon is happy with. He doesn't want the mucosa to invert and a leak to cause. So there is
Yeah.
the principle of physics, I can't remember the name. When you swallow, the mucosa inverts and it reduces the leak rate. That is what they claim. How comfortable are we all in giving post-op radiation therapy after laryngectomy? So many of them need it. How comfortable are we in allowing that? I think only if we put in an augmentation flap, we might be able to do that. I don't know what is the collective experience here in the Kannava. I'm sorry, I've
No, sir.
Ashok.
Uh,
David?
there is always, if there is no fistula, the wound has healed very well. I think 6 to 8 weeks is very optimal. I'm not worried about it. The problems come when they have fistula and they stay in the hospital for 2 months and then they go home with a very tenuous healing. And then you are worried whether the radiation will cause more problem. I think that is always a give and take here. We don't do want to start the radiation within 6 weeks, but if there is a major wound issue, I don't think you can start it. And then we delay it. There have been some papers in the literature about the higher rate of recurrence if you delay the radiation by more than 6 weeks. I think Vikram was one of the radiation oncologists at Memorial who popularized starting the radiation within 6 weeks of surgery.
So another practical point in patients who have had a leak. So if you have conservatively managed a leak and the leak has stopped, it stops and you don't get saliva anymore. The general teaching is, or the practical point is to wait for another week, because usually these leaks heal by granulation tissue. If you immediately start feeds, that granulation tissue bursts, and we have seen it reoccurs, the leak, and then it is very difficult to control it. So wait for a week, let the granulation tissue mature, and then start your radiation stroke oral feeds. That's a practical point for the students. Yeah, but as Dr. Shah said, 6 to 8 weeks is a good time to start radiation.
Kanab, deeply apologies. I called up for the chat question. For my take, as long as the patient is swallowing well, there is no leak, airway is clean, and all wounds are healed well, I start, and that's majority of the patient. Few patient, if there was an early leak, I delay them as long as possible and balance with the rate of recurrences as well as the completion of the treatment. Any leak which opens up during the treatment is more detrimental than starting bit late. So that's what I aim for, that during the treatment, there should not be any breaks. And definitely, as Dr. Saha pointed out, that was Dr. Vikram Bhadrasen, who laid one of this retrospective paper of adjuvant radiation. Optimal time is within 6 weeks, but there are several papers to that. Dr. Peters, who promoted at early radiation versus late radiation and how to counteract the delayed treatment strategies by giving altered therapies.
So if we can move on to the next case, this
Was
is
really?
probably the last case that we'll take. So this was a 61-year-old gentleman, businessman by occupation, complaints of hoarseness. This was his fiber optic laryngoscopy that showed a infiltrative growth at the anterior commissure, bilateral cords freely mobile. As required in anterior commissure lesions, he had imaging. Aditi, if you could give your take on these scans.
Um, okay, so this is an anterior commissure lesion with slight extension on the right cord. I can see these are two sections just within short range of each other. Here I can see the anterior part of the thyroid is not ossified on either side. But here, this is where I can see that there is some enhancement in the place where I would have seen the thyroid, unossified thyroid cartilage. And there is also bulging of the lesion anteriorly, further from the margin of the thyroid cartilage. So this is where I think there is some amount of cartilage invasion and suspicious extralaryngeal spread. This will be an ideal case as described, where we can do an MRI now. I'd like an MRI one because to confirm the cartilage erosion, cartilage involvement and extralaryngeal spread, if any. And because secondly, because in these cases, anterior commissure lesions, if present, it will upstage the disease and affect the treatment decisions. So if we get an MRI, we can confirm that.
So there was an MRI done for this patient. The MRI also this was suggestive of cartilage erosion. So Pradhan sir, how would you like to manage this anterior commissure lesion in this 61-year-old gentleman? Would you offer him any form of voice conserving surgery?
No, I think that I think that total laryngectomy is probably the best option. There is an option of doing a supracricoid partial laryngectomy with a cricohyoidopexy or hyodoepiglottopexy for this case. But it has all those problems of post-op period being very strenuous, the voice quality not being good, but cure rate's good. If you do a laryngoscopy and see that if you do a 0 degree and see that the subglottic spread is minimal, then this is a case that can be treated with a supracricoid partial laryngectomy. The other option is a total laryngectomy. I think
Dr. Chopra. Yes.
we've done a supracricoid on him.
Yes, sir.
Yeah, okay, all right.
Certainly, I think I am offhand here, sir. I don't want to venture out. That is one. And secondly, Kanav, there is some questions in the chat box for you.
Yes, sir. Dr. Chokar, your
Agarwal, before we go ahead to the chat box, yeah, I agree with sir that this is one of the few indications again left for anterior commissural lesion with cartilage erosion. You can do a conservative laryngeal surgery provided the pulmonary functions are good, so on and so forth, because there will be some either aspiration initially to begin with till the patient regains his swallowing therapy. A question to Dr. Agarwal: cartilage erosion in 0 patient, minimal exolaryngeal spread. We've done a supracricoid. Can we avoid radiation with a clean surgery, or you would like to radiate this patient because it's a T4?
Uh,
Because
See, if it is a
after
minimal,
conservative surgery, will push the patient back.
thanks, Chokar. See, cartilage invasion and there is a exolaryngeal spread. So these are likely to have a higher chances of recurrences. And that's the reason a post-op adjuvant was given in historically. But since these patients have a lot of problems in the post-op, right? So most of the time they get delayed and delayed because of the aspiration. And my adjuvant treatment further cause the morbidity of aspiration. So I think we now realize that uh, whatever we do, we don't increase the morbidity of these patients. But having said that, definitely these patients will require some form of adjuvant treatment from us.
Yes, sir. Kanav, did you radiate this patient post-operatively?
that is something that I wanted to bring up is the tolerance
Oh,
after.
sorry, I stole your thunder. Sorry.
No problem, sir.
Apologies again for my side also.
Very few partial laryngectomy procedures tolerate postoperative radiation therapy.
Right. Right.
I concur, completely concur. Because of the swallowing issues and the aspirations. And they don't complete the treatment in the optimal time. So we are the losers on both the sides.
No,
But
the mucosal post-radiation mucosal edema is a problem. It's not so much aspiration.
yes, sir.
Post-op,
Yes, sir.
post-op mucosal edema
That is
Rogers'
okay.
quality of voice also.
Agree, sir.
So, Kanav, again, a point to think over, as Dr. Pradhan initially, when he saw this CT scan and the description said a total laryngectomy, and that you should keep that in mind. Though technically supracricoid is feasible, for a better control, maybe in this patient with cartilage erosion, 64, exolaryngeal spread, maybe he'll do better off with a total laryngectomy and postoperative radiation therapy rather than a supracricoid. If it was only an anterior commissure disease close to the cartilage, is supracricoid still can be an option with little minor cartilage erosion. But with exolaryngeal spread, I would add radiation therapy with supracricoid becomes that much more difficult. So a very call to take, but I would then go ahead with total laryngectomy with postoperative radiation therapy for disease.
With both vocal cords so freely mobile, posterior part of the larynx so very good, one doesn't
Very
and
difficult, but
and the local regional control rates with supracricoid partial laryngectomy are extremely good. The best local control rates that any partial laryngectomy can give. Upwards of 90%.
I agree, sir. But right, sir. But considering it was exolaryngeal, in the olden days when CTRT was not there, supracricoid was for an anterior commissure lesion, which was either a bifrontal or a supracricoid extending to the cords. But with the exolaryngeal cartilage invasion, as Dr. Agarwal said, this patient would better off with a better control with postoperative radiation therapy. Keeping that in mind, I said maybe a total laryngectomy would but certainly supracricoid will be in the decision making when you're taking the decision.
True. True.
So there are a couple of questions in the chat. One by Dr. Praveen is, I think, management of the thyroid gland during a total laryngectomy.
Let me take that because this has been a subject of debate over last 40 years, and we have seen through that. So one of the things we need to appreciate is the thyroid gland is right next to the cricoid cartilage. Can the tumor come through the cricoid cartilage and invade the thyroid gland? That is something you have to determine before operation or during operation. Those are the cases where you would take one lobe of the thyroid. Try to avoid taking out the entire thyroid for a variety of reasons. Keep in mind, why do we take the thyroid out? Either the proximity of the tumor to the thyroid gland or the invasion of the tumor into the thyroid gland, or more importantly, paratracheal lymph nodes, level 6 and 7 nodes. So it's the responsibility of the surgeon in the operating room to evaluate all these. If that is so, take one lobe out for a better oncologic procedure. Now, the problem is as follows. If you decide to take the whole thyroid out, now the patient is on thyroid medication for the rest of life, number one, and the risk of hypoparathyroidism is highest in this group. The highest hypoparathyroidism you see, post-op hypoparathyroidism, which is extremely difficult to manage, and patient ends up in the ICU, are the patients where you have done total laryngopharyngoesophageectomy. You did the central compartment clearance, and all the parathyroid glands are damaged or removed. Those are very difficult problems. So be very careful when we talk about thyroid lobectomy or total thyroidectomy. Now, if both the lobes look clean and the tumor is truly intralaryngeal, I don't think you need to take the thyroid.
So for the students, thyroid involvement, as Dr. Shah said, is high. It's about 40% in literature. It's higher when you have a subglottic disease, pyriform disease, or disease that is, as he said, nodes in the paratracheal area. Then you remove that half of the thyroid. The opposite thyroid is generally in majority, 99.99% of the cases saved. So you remove only half of the thyroid in majority of the cases. You may not even do that if you have a supraglottic disease without central compartment nodal disease. Then these thyroids are never ever involved. Involvement occurs only when you have subglottic disease, pyriform disease, or paraglottic nodal disease. Only then you need to remove the thyroid gland.
Very nice.
And
There was a question in the chat, maybe we can just bring it up. The role of Botox in pharyngeal fistula. I will summarize. There is hardly any data. All these adjuvant therapies, Botox, etc., are individualized. These are the frustrations of the surgeons. They don't know what to do, then use whatever is available. Instead of Botox, I use the Ganges water. It works very well.
The holy Ganges. It will add up more infections, huh?
No, that is the most purest water.
No, so I understand, sir. But exactly the question is how the Botox was used. If
I,
Dr. Kendrick can give some thoughts on that.
I
Dose,
have some idea.
intervals.
Oh, I usually start with 25 units per gland, submandibular and parotid. You can go up to 50 potentially per gland as well. I try to go pretty conservatively at first just because it obviously can have the significant effect of too dry of a mouth and intolerable for the patient, but 25 is a safe starting point.
Both the parotids, both the submandibular,
Yeah, both the simulators, both the parotids, yeah.
or only on the weak side.
I have thought about that. I don't think,
I'm sorry, I'm
you
extending the
know,
question.
yeah, no, I mean, I think because, oftentimes it's so often the base of tongue, I haven't thought about doing just one on the leak side. Because I feel like it's all going to end up in the same lumen anyway. So I often will just do both. I have sometimes done just submandibular glands too, just because of ease of access. But yeah.
So if I have some liberty, Kanav, can I ask one question?
Sure, sir.
Okay, so basically parotid gets stimulated when we see food or the act of swallowing some food, etc. So do you think we can decrease the dose to the parotids rather than just give it to submandibular? So when we eat food, parotids are more active at that time rather than all the time. So can we do some selective issues of not injecting the parotids? Or after injecting, how they have regained the function? Because otherwise they will blame us. Radiation oncologists, you have made us dry.
This
Sir, I
que-
don't think
this,
much
this,
work Botox.
this question only
Advanced
arises.
truly.
This question only arises if you are sold on using Botox.
No, sir. I'm trying to brace myself.
I don't want to use Botox. Okay.
So have you seen more xerostomia in patients of Botox when after they have given radiation?
Kenrick, it's to you.
I'm sorry, the connection's a little bit poor. I didn't
Okay.
quite catch that.
So the question is, the xerostomia, a temporary xerostomia lasts for how long?
It should be about 3 months or so.
3 months.
But yeah, I mean, repeat injections will eventually atrophy the gland, and it could become permanent. So I don't do it a second time.
Great.
Yeah, it's really just a temporizing measure in the beginning.
Okay.
Yeah,
Thank you. Thanks, Ken.
of course.
So if there aren't any further questions, I think we can end this session here. Any closing comments from Professor Shah, Dr.
Well, my
Pradhan?
only closing comments are, I think we have made enormous progress, both in larynx preservation, organ preservation, and now something coming up with the immunotherapy. I think we are still on our learning curve. We have learned quite a bit about organ preservation. I think Greg Wolf was one of our friends who started this, and it was pretty innovative. The pharyngeal or the hypopharynx trial was started by John Louis Lefebvre, who was a good friend of all of us. And I think that was probably a unique experience that even in hypopharyngeal cancer, early hypopharyngeal cancer, you can use organ preservation strategy. And we were able to preserve the larynx in 60% or 66%. The major question is it just the preservation of the larynx or or functional preservation? I think that is very important. And I think we learned over a period of time which are the right patients for total laryngectomy. One of the questions that comes up in the tumor board when patient presents with advanced larynx or hypopharyngeal cancer is, am I just going to delay the total laryngectomy that patient invariably will need? I think that's the question that comes up. And I think Dr. Pradhan made it very well, explained it very well, that there is total laryngectomy is an indicated procedure in patients with very advanced laryngeal cancer or hypopharyngeal cancer who may be benefited with primary surgery rather than going the route of organ preservation and then considering surgery, which may be more complicating. So that is one other thing. I just want to bring up one other point, and we may not have time in future, but there is something called as functional inoperability. I think I just wanted to expand on that. You know, there is very little that we cannot operate. We can operate on anything and everything. Dr. Strong, who was the chief of head and neck service, used to say, you can do the guillotine operation and cure everybody, but that's not the right way to handle the patient. And there is a lot written or discussed about the functional inoperability. There is a very nice paper published from Amsterdam by von Baum, Balm, and he talked about functional inoperability. And the functional inoperability comes in with the consideration of age of the patient psyche, their understanding, the nature of the disease, and the future outcome. So the functional inoperability is something that we need to put in the equation, and that comes when you have stage 5 disease, more than very advanced disease. Technically, you can operate, but emotionally, you don't think you will be able to help the patient, and the tumor will recur. So those are some of the issues, Kanav, I wanted to bring up for the audience to think about when they go home.
Thank you, sir. Dr. Pradhan?
No, I think you've done the session both the sessions you've conducted very well. And all that our students need to know, you've highlighted them very well. And all the panelists also contributed very well. It's a very good thing. Very well conducted. Voice conservation surgery, my books are now slowly becoming just a footnote in surgery. That's the progress that science has made, which is good. It's very good.
So it's time for the other edition.
Yes. The other edition will have a footnote on open
No, I think
transoral laser surgery is a great thing, a really great thing. And
so.
chemoradiation is a great thing. I think it's a wonderful thing.
So if I have to give a take, sir, I think complementing the fiber optics, which has made our vision little more clearer.
Yes.
And the imaging, I think Aditi has done a remarkable job. And I think we need to work on our imaging with radiomics and also something on molecular to understand which will work much better for the organ as well as function preservation. Though we are seeing the tip of the iceberg now, I think with the time, oral cavity will come down, larynx will increase. So we are in the business to help our patient much more to improve their quality of life. I think that's the take I will take at this time. Thank you, Kanav, for giving me the opportunity to be with legends here. Thanks, Devendra.
Thank you, sir. Dr. Pradhan, Dr. Shah, can I make one controversial statement, a bit controversial? I think the pendulum has swung too much on organ preservation.
Yeah.
We need to select our patients better. I see that any T3, T4, stage 3, 4, straight away without thinking patients are being sent for organ preservation, especially hypopharyngeal cancer. Salvage is extremely difficult. Majority of them will die of aspiration, and that is why you have these increased mortality happening. So we have to be very careful in what we selected, as Dr. J.P. Agarwal correctly pointed out. Going ahead, personalized medicine will be the future. But organ preservation, we need to deal with it. I think we need to revisit it. We've swung the pendulum on the other side. We need to revisit it. In certain cases, partial laryngectomies, laser surgeries, and even total laryngectomies for that matter, serve the patient much better than organ preservation techniques. So I think it's time to revisit organ preservation techniques.
Very true. Very true. It's a good caution that you have sounded, Devendra. Very nice.
Dr. Tam wants to speak something, and the participants.
I have
And
nothing
that,
to
and
add,
that,
but thank you for inviting me.
and that, Devendra, that is the reason why I very often plead with Dr. Saikia to give neoadjuvant chemo for
Yes, sir.
biopsy. But they don't agree. They're not comfortable.
They will love with 689 coming in, so they will love giving you a June.
No, sir. It's a we really need to select, sir.
So I'll tell you what selection I'm talking about. If I find a patient who's amenable to open partial laryngectomy or even to a near total laryngectomy, I don't want to do those procedures if he's going to respond to chemoradiation. But if he does not respond to chemoradiation, I have lost that opportunity of offering him surgical voice conservation. And that is why I plead with Dr. Saikia. He's looking at me just now. I plead with him, give neoadjuvant chemo. If I find a good response, and so often I find very, very good response, like the slide that Kanna showed. A beautiful response, you can hardly see the disease now. Then I'm very comfortable treating him with chemoradiation. So
Yes,
So my take is, sir, we have to predict on our diagnostics, imaging, radiomics, something molecular rather than giving. So I know you think that you have lost the battle the moment you send it across and we refuse. We need to go extra mile in our labs, in our diagnostics, to convince you that this is the patient for who is going to have a great response. I know Dr. Saikia said he doesn't know at this point of time who will turn around and have the best of the world, that he has a complete response on imaging. But we have to go extra mile to find out before even giving that injections and radiation, sir.
so, so I will come in now.
yes,
It
yes.
was a wonderful session. I am enriched. I am sure the students are too, all young people. Yes, sir, the induction therapy, we are all for it. As medical oncologists, we have. First thing is safety, sir. Now that we are giving chemotherapy drugs, I think that we need to work more on that, how we can make it very, very safe. Drugs, now we know 5FU, how to use it by looking at the enzyme. Similarly, I think platinum we know a lot, but I think there's still something we need to know. Taxanes, yes, but taxanes are at times unpredictable. So from medical oncology point of view, we have come some distance, but we still have to go a long distance. And now that immunotherapy is coming in, probably we're going to change a lot, sir, using pre-op systemic therapy. I think we are moving in that way, and I'm more comfortable in 2025 what I was in 2005. Sir. 2005, 6, I say about a text 323, 324. Those are pretty toxic regimens.
Dr. Saikia, can I just
Yeah.
that? As you correctly said, we get safer drugs. I did the Mandel trial, sir. One of the was you're giving a very highly toxic regime, the 3-drug regime for saving the mandibles. And my answer to that at that point of time was that over the years, the regimes will get better, we will get better, we'll get better drugs, less toxic drugs. So this is a proof of principle that reducing disease, you can conserve the organ. So and it's happening now, sir, with immunotherapy, that we are getting fantastic response with minimal side effects. So point well taken. As we move ahead, we have to get better drugs, less toxic drugs, and we will be probably finding the answer of which patient to give organ preservation.
Right.
Thank you. Thanks a lot.
Thank you all.
Thank you. Good night, everyone.
Thank you, sir.
Bye-bye.
Good night.
Good night.
Thank you. Thank you, Kanav.
Dr. Shah,
Thank you.
pleasure again interacting with you. Bye-bye.
Thank you.
Bye
Bye-bye.
bye. Bye, everybody.
Bye.
Thank you, sirs.
Okay, bye.
Thank you.